Okay, well, welcome to our AO Trauma North America online series. We're going to be having our 3 cases fireside series discussed today, and the topic will be Zone 2 flexor tendon injuries. And I want to thank our chair, Marco Rizzo, for his leadership for this series. And then your faculty today will be me as the moderator. I'm Sonu Jain at the University of Cincinnati. We have our sage, Dr. Jin Bo Tang, who's at Brown University and currently in China. And our faculty is Dr. Maureen at the University of Kentucky. And also in Lexington, we have our hand therapist extraordinaire, Greg Pitts, at Commonwealth Hand and Physical Therapy. So you have an Ohio Valley group here with Dr. Tang as well. So welcome. And this is our disclosure information. This is our content validation statement. This is a CME program. Please be aware that your CME link will be sent to you in December when the series is over, so you'll not get it immediately after this webinar. So keep that in mind. Later this year, you'll be getting that. So Zoom etiquette, please have your microphones muted, your video cameras turned off. Your questions should be sent through our Q&A, question and answer box. We will review them and answer them. And the chat box is for faculty use. And this is our agenda. And let's see here. And these are objectives. These are upcoming AO webinars and our online series. And we have our AO Trauma Hand courses coming up as well, which is our Fellows course in May, and our Hand and Wrist Fracture Management course in November. You can access the recording on YouTube. The link will be sent out. We have our OrthoTV online channel. And I'm going to begin by talking about the evaluation and management of Zone 2 flexor tendon injuries. A little bit of the background. So we have obviously Sterling Bennell, who described no man's land, which is this area of the flexor tendon sheath. Was based upon the strip of land back in the trenches of the opposing armies in World War I. And these areas failed due to infection, excessive scarring, and flexor contracture. This is the Zone 2 that we're talking about at poor outcomes. And Joe Boys in Los Angeles described, grafting as the preferred technique for this. And then Kleiner and Kutz out in Louisville changed that paradigm back in '67 and discussed the primary repair of flexor tendons in this no man's land. And that was a turning point to how we really address some of these complicated injuries. So I'm not going to belabor this. It's just to be thorough, just show you flexor tendon structures. It's much more fine than just a big mass of tendon. They actually have collagen fibers, which is surrounded by other fascicles and fibers. Tendon nutrition, the perfusion is a dual blood supply. One is vascular, one is synovial. It gets it through the vincula, which is inserted dorsally, which is a pretty good blood supply. And you want to protect this during your repairs. You don't want to sacrifice these. These are what really gives a lot of the nutrition to the tendon for healing. And then you have your tendon healing pathways. I'm not going to belabor this. Again, this is just to be thorough and just understanding the healing process. And you never really achieve full pre-injury strength. So we are talking about Zone 2 injuries today. So just want to know the anatomy of your flexor digitorum superficialis, origin insertion, and primarily flexing your PIP joint and assist the MP joint. And be aware that the small finger FDS is absent or underdeveloped in about 25% of your patients or population. The FDP, again, inserts the distal phalangeal bases of the fingers. It's dually innervated by the AIN and ulnar nerve from radially to ulnarly. It flexes the DIP joint and assists the proximal 2 joints, which are the MP and PIP joints, and they do have a common muscle belly. The FPL, flexor pulsus longus tendon, innervated by the AIN, flexes the thumb at the IP joint, is the most radial tendon in the carpal tunnel. So be aware of Camper's chiasm is the decussation of the FDS tendon split by the FDP, and you have a synovial membranous portion and the tendinous portion, just to be aware of when you are seeing these injuries and you are trying to evaluate what is what. So we're all aware of these pulleys. We were taught, and this, sacrosanct A4 and A2 pulleys will be destroyed today by Dr. Tang, because we will show that we were told not to violate these, but it's been shown that you can do that and get good outcomes and get good repairs. So this is a nice anatomical a photo here, which really shows the topography of where your pulleys are. And I like to use this when I'm looking at the fingers to mentally figure out where my pulleys are. So that way I kind of know when I'm making my incisions where is what. So thumb pulleys, you your oblique, A1, oblique, and A2. And the pulley biomechanics. So this is important. So the amount of finger flexion is proportional to your tendon excursion and inversely proportional to the moment arm. So when you have that increased moment arm, as you can see in the second slide here, or the second cartoon, it increases the pulley efficiency, because what happens is you get the maximum excursion of the tendon before the fingers fully flex. So that's why it's really important to have your pulleys, because they allow that efficiency of motion to be able to get the full tendon flexion, finger flexion with the tendon, I should say. So, assessment of the injury. So you have to have a proper history. You want to get the timing mechanism down. Physical exam is very important. Location, loss of the flexor cascade. That's something that you can do without patient involvement. You just look at the patient's hand, look at the resting posture. Based on that, sometimes you can have an idea of what is injured, whether there's no tendon injured, whether there's one injured, or maybe both of them. Adhesion formation, that's more for your delayed presentation patients. Pulley injury, potentially. Joint contracture, again, for more of a delayed patient scenario. Neurovascular injury, and then consider x-ray depending upon the mechanism of injury. So low threshold to get that. Even with, sometimes you could have a sharp blade injury that could be pretty strong. You could actually get bone injury with those. So have a high index of suspicion for that, depending upon the mechanism. So these are the zones of injury for the flexor tendons. We're not going to talk about all of them. We are focused today on zone 2, just to show you where everything's at. So this is the proximal aspect of the A1 pulley to the FDS insertion. They have poor outcomes historically. We talked about no man's land earlier. Increased adhesion risk. It's a tight space for two tendons. We're going to make them less tight. So when we fix them, they get caught underneath the A2 pulley, and then the repairs rupture due to poor vascularity. So, again, we talked about preserving the vincula when you're doing these. Don't take them out. They're intact. They sometimes hold the tendon out the length, and you don't want to take them out trying to repair it. You're not doing yourself any favors. And you want to fix these fairly quickly, within a week, week and a half or so, to get that together. This is one of my favorite slides, and again, I have to credit to Dr. Tang. I really, whenever I talk about flexor tendons, I like to show what was done before and what is done now. And I'm not going to go over all of these, but I think there's some key points here. Was that, we used to talk about 2-strand, now we talk about doing 4 or 6. We talked about A4 and A2 not being violated, and A2 can be partially vented, and A4 can be completely vented if needed, and that you don't have to repair the sheath, and you want to really focus on the amount of grasping of tendon that you want to take when you're doing the repair, so you're not trying to repair the tendon like a nerve. So these are things, and I'll let obviously Dr. Tang is here, so he will describe his techniques more in detail. But this is you can get this from clinics and plastic surgery. Is really good and really gives you a nice summary of how to really look at flexor tendon repair today. So you can have partially division of these. It's been shown that in the animal and cadaveric models, you get decreased work of tendon flexion with the A4 excision that went intact, and that even tendon strength was actually found to be stronger when you divided the A2. So in some respects, the pulleys, even though it protects your ability to get that efficiency to some degree, we're not seeing that clinical bowstring. And number 2 is you may actually be getting better strength, at least based on these models, with healing. So again, I'm not saying that's what happens. There may just be some thought that this may be happening. And then obviously in the thumb, A2 division did not have any effect. These are possible locations of lacerations, and this is where you can potentially release these pulleys. Again, I will defer to Dr. Tang on this in more detail. So when you are repairing these, you want to have meticulous attention to the technique and detail. Core sutures provide the majority of strength. You want to grasp at least 7 to 10 millimeters on each side. You want to use larger core sutures, which will be equate to stronger core sutures. And you want slight tension at the repair to minimize gapping. So you want them bunched up a little bit. You don't want them to be a nice, pretty repair like you're repairing a nerve. And then the strength is going to be proportional to the number of strands across that repair site. At least 4. I try to do 6. Suture material should be a 3 or 4 braided polyester. Failures usually occur at the knots. And again, you want a slightly bulky repair at the site to prevent gapping, because that will be where you will have failure if that happens. So this just shows you different repair techniques or so. I would just recommend people doing the repair techniques that work well in your hands. I personally use a modified Kessler. That's what I've been doing, and that's what makes most sense for my hands, and I've had good results with it. So try different things that work for you and see what you're comfortable doing. So the knot location, essentially, there's no consensus. The thought is that the outside is stronger initially, but equal at 6 weeks, and you get one is stronger than 2, which makes sense. If the failure is at the knot, then it makes sense to have 1 knot rather than 2. But again, it's not critical. I think the only benefit of putting the knot on the outside, especially now that we're venting these pulleys, is that you don't have the knot in between your tendon repair. So I think not having a bulky knot in the middle of your repair site may actually help your tendon have better strength in terms of intrinsic tendon healing. So I don't typically put my knots internally. I usually leave them on the outside. So obviously locking is stronger than grasping, which the latter may result in gapping. You want to avoid this 3 millimeter critical gap. So you want the strength you want that to be solid for at least 6 weeks, because that's your critical time period where you get that strength to accrue to allow that healing. Epitendinous sutures, prevent gapping. They can produce a smaller volume of the repair site to improve gliding under the pulleys. So not as critical if you're venting the pulleys, but there are some ways to make this a little bit, add a little more strength and to kind of, make your repair site a little bit less, prominent or protuberant. And it can increase the repair strength as well. But it's not as important now as we used to consider it with our more liberal pulley releases. And these are just different techniques of epitendinous repairs. So this just tells you that 6 is stronger than 4, which is stronger than 2. And then if you add an epitendinous portion to that, it makes it even stronger. So this makes sense logically. So you want to assess your repair intraoperatively. Try to do this under wide awake local anesthesia, no tourniquet, or you could do it under sedation if your patient's uncomfortable, and you can wake them up and have them actively participate. Ultimately, at the end of the day, you're testing active motion with patient participation to make sure there's no gapping here. So this is going to be important. Again, I think Dr. Tang will talk about more of that later on. So again, I think Dr. Lalonde has really described this quite in detail around the world. And I think if you can do these under wide awake local anesthesia, I think you can assess these things effectively. So you can test the range of motion prior to skin closure. You can have decreased rupture rates because the gapping can be visualized at the time of surgery. You decrease tenolysis because you are, making the adjustments, during your operation, make sure the pulleys are not in the way of your tendon repair, and because you're actually going to be more comfortable with having your therapist move the patient early and more aggressively, because you're confident in your repair and you're not going to have that scar tissue form in your patient as much. So this is a video of mine showing that, really the repair, no gapping, and that a full excursion. So I want to make sure that I can get full flexion and full extension, that my repair is not being held up, and that there's no gapping. So you can assess this when you're doing this wide awake or under sedation to wake him up. So partial lacerations, I'm not going to go into great detail on this, but just that really, anything if you have a laceration less than 700%, you don't necessarily need to fix those, and even up to 90%, you really don't need to fix them unless they're really getting some triggering or so. But again, this is kind of what's been described. I think different, you can do whatever's comfortable with you. If you have a big partial laceration, you feel comfortable repairing it greater than 50%, it's not unreasonable, especially now with, not having the pulleys in the way with motion. I think you can feel more comfortable creating more of a bulk there. But again, there is some data to show that, for some of these larger cross-sectional lacerations, you don't need to repair them unless there's triggering. So this is a patient of mine who 3 months, I did a small finger FDS and FDP repair. And I mean, you can see with these techniques, you can really get a great outcome with some of these. And again, this is one of those that I did with Roland as well. So I'll end my talk with a case of a 22-year-old young lady who sustained a knife injury to the volar small finger, ring finger. She notes loss of motion in her fingers and numbness, was taken to the OR for exploration. And just looking at this cascade, you could tell that likely both the FDS and FDP is out on the small finger, and perhaps the FDS may be intact or partially intact on the ring finger. That's a suspicion just based on this cascade, and that the FDP is out, which is kind of neat. So even just in the resting posture, you can get a real sense of what you might be getting. And so went in there, and you can see she had lacerations, and I think her ring was a near complete of the FDS, maybe some small little minimal amount attached that was allowing it to bend, as you can see in that upper portion of the photo here. And I retrieved these from the palm, and I use hypodermic needles to keep them out to length, so that way when I do my repairs, they're not under tension. And I repaired these. I liberally opened the pulleys here to get this. Part of it was in the zone of her laceration, but really to get this to be repaired, I made sure that when I did this, I could assess this intraoperatively for both of these. And I actually repaired her, FDS and FDP tendons in both of these fingers, similar to that other patient I showed you. And I'll ask this question to our faculty in a moment here. So the take-home message from my talk here is be suspicious of these flexor tendon injuries and address them early. The strength is proportional to the size of the suture and number of core strands. And you can assess these in the OR with active motion by the patient. So let's see, I'm gonna stop sharing here. And so I was gonna ask our faculty. So, and again, I don't want to steal your thunder, Dr. Tang, because you may be addressing this, but I feel with the assessing the patient intraoperatively in the OR, being more judicious with the pulley releases, I feel more comfortable with repairing the FDS tendons, where in the past we were told that, well, don't, if you're going to repair these, just repair the FDP and don't repair the FDS, because now you're going to create this massive, complex of two scarred tendons gliding under a pulley that's never going to move. So you're going to have a beautiful repair in the OR, and you're going to have a stiff finger at the end of the day. But, with these releases now, I don't second guess repairing these if it's repairable.
Yes, for the FDS, if you feel it's easily repairable, I would repair it. But if the surgical incision narrow or the FDS has been retracted far proximally in the delayed repair, I would not do that because that's too difficult.
Excellent. Dr. Shaughnessy, any thoughts on your end?
Yeah, I usually will try to repair it. I think it makes sense. That way you've got 2 chances of success too. So I err on the side of fixing them whenever possible.
Yeah, I know. Greg, have you noticed any difference with with that now, with more of the active motion in the operating room with some of these patients, and what you're getting in terms of outcomes?
we're getting better outcomes. The biggest thing is that the index, middle, ring finger, you can be quite a bit more assertive than you can the small finger. Small finger, because the tendons are so small, we really worry about rupture. 50% of all ruptures are small fingers. So you really, the big fear of rupturing a small finger.
Yeah, I think, you know, and I think going back to your point earlier, Dr. Tang, also, I think for, you know, the ones that wouldn't repair, those really minimal, almost like vestigial FDSs that have no real substance. So your suture is going to rip right through it. So I think you need to have something that actually has some substance to actually hold the suture, or actually hold, you know, at least a 4-core strand repair if you're going to do that. Excellent. Okay. Well, I will lead into Dr. Tang's talk here. So, Chris, I'll let you go ahead and play that.
I'll talk about Zone 2 flexor tendon repair, the technique detail. The basic requirement for all the FDP tendon repair in Zone 2 include, first, the suture purchase. We need to ensure sufficient suture purchase. I suggest about 7 milliliter to 1 centimeter. This will put the cone suture much away from the tendon junction site. The tendon junction site will soften in the first few weeks after surgery. If you put it too close to the suture, to the junction site, the grasping strength or locking strength will be very limited or very low. If you use a locking suture, the size of lock should be about 2 milliliter. The size shouldn't be too small, otherwise the lock will be easily slipped. We should keep the junction site as smooth as possible. However, the junction site does tolerate some degree of bulkiness. In fact, a slightly bulky repair will be more preferable than a very smooth repair. In making a surgical incision, the traditional teaching is use a Brunner incision. However, a small incision, the short incision about 2 centimeters in length, is possible to make a tendon repair, and also is more ideal in terms of decrease gliding resistance to the flexor tendon after surgery. Such a extension of the laceration are usually made distal to the laceration site, as the tendon is usually cut in the flexion position of the digits. So distal extension will make surgeon easily find the distal end. In finding the proximal end, sometimes you find the FDP tendon retracted far proximally. You cannot find in such a small incision. In that case, we always make a proximal separate incision in the palm. Then you find the FDP tendon on the FDS. Then use 2 forceps to push the tendon distally. I do not suggest you make a proximal extension in the digits, because any proximal extension will add edema, then add resistance to the tendon gliding after surgery. Avoid a lengthy incision in the digits and use a separate incision in the palm to find the retracted tendon. About tension of the repair site junction. Of course, the loose suture you see in A is not a good repair, as everybody knows. How about B, which is a very flat repair? It looked great in the surgical table, but with the early after motion, such a very flat repair will easily gapping. The ideal repair is C. You have slightly bulky repair with some tension. which make the repair site about 20 to 30% larger than the diameter of the tendon. Then with the proximal tension, such a slightly bulky repair will become flattened during tendon active motion. I suggest 20 to 30% of increase of the tendon repair site, which is much more safer than a flat repair. About surgical repair method, I always suggest the 6-strand repair. With year of practice, I would suggest our colleagues upgrade any 4-strand repair to 6-strand repair, because with only addition of 5 to 10 minutes, you will get much safer early active motion. And also you will see the tendon repair site is much more stable and solid with this kind of 6-strand repair instead of 4-strand repair. I use M-shaped repair most often, but sometimes if the looped suture is not available, I use 6-strand asymmetric capsular repair. That is 3 group of the capsular put in different level. So you will not have all the 3 group at one level. That is very easily strangulating the tendon and narrow the tendon segment. And I always put knots outside the tendon surface. If you put the knots in between the tendon junction site, you actually put a foreign body in between the tendon ends. That part will never connect with tendon tissue in healing process. And also with the knots inside the tendon between the stem, you create a gap inside the tendon, which is also a risk factor for rupturing. In either method, in the slides, either M-shaped or a 6-strand asymmetric capsular, I always put the knots outside the tendon over the tendon gliding surface. With the venting of a poly, this kind of exposed knots will not cause a lot of problem. In making an M-shaped repair, I use looped nylon suture. There's different company produce looped suture. In Asia, in Japan and China, we have separate company produce looped suture. In United States, North America, and also in Europe, mostly use Supermit. In the United States, S. Jackson produce and sell Supermit. In Europe, the German company you see in the lower part of slides sell the Supermit to many European countries. Such an M-shaped repair become quite popular in many European and American countries. The suture through one funnel through the middle, and then go to the opposite side, and then the transfer suture, then go back to the original stem. That's complete a U-shape. That's making U-shape. That's 4 strands. After that, we add a central one sume suture, which makes the total of 6 strands. After that, we put just a few stitches of peripheral suture. With a very solid 6-strand repair, we do not need a traditional
peripheral suture. We only need to put a few separate stitches, such as 2 or 3 stitches of circle across to close any big gap which left with a 6-strand repair. If there is no any gap seen, you do not need any peripheral suture. In fact, in some surgeon in Switzerland and Europe, in the UK, they do not use peripheral suture. I always use 2 or 3 if I see the gap, make it a big gap become closer. Peripheral suture up with a 6-strand repair does not serve to provide strength, but just to close some gap. There's no need to have a complicated peripheral suture. As you can see in this slide, the 6-strand repair is completed with white suture and then 2 black suture, that's 6/0 nylon, just serve to smoothen that, to make the gap disappear. After 6-strand repair with separate stitches of the peripheral suture, you test the quality of the repair with the extension flexion test. As you can see here, with the digits flex, digits extend first, then flex, you see there's no any micromotion at the repair site. The repair construct very stable. In a digital flexion, no gap. In digital flexion, there's no any impingement of repair site against the sheath or poly. If there is any impingement, you release the poly further to make the repair glides more smoothly. And in exposing the tendon, we do need to vent the poly. This is a very important part of the surgery. Because the A4 poly is small, you have to vent the entire A4 poly, as you can see in this video. We need to vent the entire A4 poly. However, in the A2 poly area, we usually only need to vent only a part of the A2 poly because A2 poly is long, which is about 1.5 to 2 centimeter in length. You can vent about 50% or 70% of the A2 poly, retaining a small part of the A2 poly to prevent any bone straining. In rare condition, then if the entire A2 poly vent is necessary, you can perform that if the other poly is intact. But such a situation is not so commonly seen. So in most cases, partial A2 poly venting is sufficient. For protection after surgery, I use the dorsal slab from the distal or the middle of the forearm distally beyond the fingertip. The wrist and the MP joint in the wrist is always in the neutral position or functional position or slight flexion, avoiding extreme flexion or extension. The finger joint in the functional position or the resting position. Specific angle at this joint is not important because splint serve to prevent any hand use. And that's not for setting the tension. For the exercise, I always ask patient to take the splint out, do the out of splint motion. So specific joint position or angle is not important in this kind of splinting. It makes the splinting much easier and the patient more comfortable. And motion start at 4 to 6 days after surgery. The first 3 or 4 days does not need any motion. In doing an exercise, first do the passive motion, then active motion. Active motion only go up to the mid-range and avoid extreme flexion. I have used this protocol for 20 years and always go to the mid-range, not the extreme. We have a lot of experimental study to support such a motion protocol that you can see in general hand surgery about 20 years ago. This protocol, we use the Nanton protocol, has been safe and efficient. You can see how I do the motion. First, do the passive motion, that's the full range, to decrease the joint stiffness. Then, and you allow patient to active move only up to the half, avoid extreme flexion. This to make the repair side move, but not to risk it with a full fist. We use it for the first 3 weeks, then gradually aiming at full flexion actively. We do not do the place and hold. We do not do the passive only motion, always do a true active flexion motion. The rationale behind such a protocol is when the patient finger becoming progressively flex, the tendon repair site subject to a greater and greater bending force that make the extreme flexion extremely dangerous. So avoid extreme flexion. That is site tendon easily disrupt. If you only do the partial range, that's half of the fist, they're very safe and will not easily gap in the tendon or rupture the tendon. I always ask patients to do the out of splint motion, take the splint off and do the motion exercise. Also emphasize differential motion of the DIP joint and the PIP joint. That's basically a FDP function. And also do the passive motion for the PIP joint, because this small joint easily gets stiffness. You should do some specific passive motion multiple time or session in a day to decrease the stiffness of the DIP joint. This is a summary of my protocol. It's 4 to 6 sessions a day. You do not need to do the arch motion, but increase the run of each session, at least 40 rounds of digital flexion, often even 60 rounds or 80 rounds. I ask patients to set a timer to record each session 50 minutes or 20 minutes rather than counting the number. I do not suggest you to do hour session because each session with the smaller number of sessions a day, increase the round in each session. That is more efficient, and also patient will like it. Patient do 4 to 6 sessions a day rather than do 10, 12 sessions a day. But in each session, go over 40 rounds. This will increase effectiveness. Here I provide some example of the tip I use in flexor tendon repair. You see here, I use very small incision. And also you see here, I vent A4 poly entirely to expose the FDP tendon distal stamp. Proximal stamp is retracted. Then we make an incision in the palm using 2 forceps to push alternately to push the FDP tendon to the surgical site in the digits, avoiding a lengthy incision in the digits. That's the edema of the same patient, much narrow edema with small incision at day 5 and 2.5 weeks. That is critical period of time for the orthopedic active motion. Small incision decrease the edema and resistant to tendon glide.
As much as I
Good.
can go.
Yeah, don't need a Foley. Very nice. Yeah, please.
This is the same patient, very small incision has been used for such a multiple finger injury and separate incision in the palm. For the FPL tendon repair, the same out of splint motion is used. Take the splint out, do the motion of the IP joint and MP joint. And this is another patient. You see the laceration site is very close to the palm, but I still push it because I don't want to have a lengthy incision just proximal to the repair site. And it can be pushed out and to the laceration site easily. And this is how I push the tendon out. For the little finger of the same patient, I also push it without extending the incision proximally. This is the same patient, two finger injury. You see the normal recovery to the normal function. Not only this patient, but also all the example, and most of my cases would like that. This is the patient. You see how I do the splinting and also take the splint out, do the out of splint motion. And this is patient of an index finger and also a patient with the FPL tendon repair. Splint put on, do the out of splint motion. Here is a list of 4 papers I suggest you to read that will give you more detail of how I perform the Zone 2 flexor tendon repair. Thank you very much for your attention. Thank you.
Wonderful talk, Dr. Tang. Do you have any comments you'd like to make?
Well, I think I illustrate most of the point. In my past 20 years, I really didn't have a lot of, or not really have a rupture. Only 2 cases in this COVID period. One is a patient who fall down, then he went to the bath and then fall down slippery without splint. The other is a small finger. He wrongly do the active motion to move against the splint. So if they follow the instruction well without this mistake, and then you do a solid 6-strand repair and vent it nicely without a very lengthy incision, you should have quite stable outcome without rupturing.
Wonderful. Well, thank you. That video of your techniques is just amazing. So thank you again. I'd like to my pleasure to introduce Dr. O'Shaughnessy from University of Kentucky, who's going to talk to us about navigating complications. Dr. O'Shaughnessy.
Thank you. Just getting my slides loaded up here. Is the view correct there, Dr. Jain?
Yes, looks
Okay.
great. Thank you.
Wonderful. So that was a tough act to follow. Like I said, I'm Maureen O'Shaughnessy coming to you from Kentucky. So here are the learning objectives to talking about another case, which is about some complications we'll discuss here. So this is a case of a young gentleman who's working in the garage in the evening, injured his hand on some sheet metal. He is a smoker, as many of my patients are in this part of the country, but is otherwise healthy. On exam, he didn't have an FDP or FDS. He was seen in the emergency department, referred for outpatient surgery. Taken for repair in zone 2, did a nice job of repairing both the FDS and FDP tendons. This is what an exposure looks like, the complete opposite of what Dr. Tang just showed. That was some really beautiful videos you showed, Dr. Tang, with the more minimal exposure. But this is what this can look like at the ruptures or the laceration site. Exposing the tendon ends, getting them out to length, placing our core sutures as we've discussed, and that's what one of the repairs can look like. And then afterwards showing a nice restoration, slight overtensioning of the cascade. He was sent to therapy, did the early motion protocol right away within the first few days in the first week. At 2 weeks and 6 weeks post-op was doing quite well. However, comes back a few months later and he's unable to bend the finger now after lifting groceries and felt a pop in the hand. And this is what a case like this might look like when he comes back again. So we didn't talk yet too much about what can go wrong, specifically with tendon repair surgery. But this is a relatively recent systematic review meta-analysis, just showing some of the complication and the more modern rates of complications with our newer techniques and surgical repairs that we've just been hearing about. So overall rupture rate is about 4%, adhesions 4%. And those undergoing reoperation following repairs up to 6%. Their study in the review of the literature found that the modified Kessler was a little bit of a better suture. However, we know that some of our other studies show that there's not really any superiority to suture configuration. So back to the patient. You know, what is the next step here? And this is something I think a lot of surgeons that have had some time in practice, really struggle with. That photo I showed was a little bit dramatic. You can sort of guess what's going on there, but there's more often the patient seems to be doing well, then all of a sudden they're just not getting that motion anymore. You're questioning, are they stuck in scar? Did they rupture? What is going on here? So I think this is where the use of ultrasound can come in really handy if you have access to a clinic ultrasound or an MSK radiologist who can look at this for you. MRI, I would argue, is not necessary to get. I think it's a pretty expensive exam, and it doesn't always give you that information because it's a static study, not the dynamic study that you tend to need to evaluate these type of injuries. And what about just surgical exploration? I tend to err on the side of this because I do find in my experience that the ultrasounds aren't always 100%. Some that we think are actually intact or the opposite, you get surprised in the OR. So for me, I will sort of have a discussion with the patient and, understand what surgery might look like. And here, again, we're facing in the setting of a already repaired digit that now is not moving. Is this simply caught in scar tissue or are the tendons ruptured? So are we looking at a tenolysis or reconstruction? I think this is where it's extremely important to have an understanding yourself as the surgeon and make sure you convey this appropriately to the patient about a very clear discussion of the risks and benefits. What if we go and we think this is just a tenolysis scar tissue surgery? What if that tendon is cut? Sir, madam, what do you want me to do? Shall we embark on a reconstruction or leave it be? And really important to set expectations so they know what they're getting themselves into. So like I said, for this patient, take him to the OR for exploration, hopefully a scar tissue surgery, but be ready for reconstruction. In this case, it was that tendons were both ruptured. So now what? Another thing that I struggle with, and I'll have some of my junior partners kind of call me about sometimes too, is in this situation, could you re-repair it or do you reconstruct it? This tends to be more of a question when you're at that 3-week point, or they come back for the first 2-week postoperative visit. You're 2 weeks from surgery, but really kind of 4 to 6 weeks from the initial injury potentially. And so for this, I'd be interested to know what our other panelists have to say, but I think you can attempt a re-repair, and if the tendon comes out nicely and it comes together, it's fine to try that, but err on the side and always be prepared for reconstruction with your silicone rod so that you're ready to go and you don't have to do a second procedure, and let the patients know those options too. So what are the more modern indications for flexor tendon reconstruction in the setting of either a delayed presentation of a complete flexor tendon injury or a failed repair? So patients that have poor or no active motion, the failed repairs, patients need to have well-healed and supple soft tissues. They also have to have neurovascularly intact tissues with good skin envelope, and good sensation and blood supply to it. You don't want to be doing a reconstruction of a patient with a very scarred in, woody digit. That's not the ideal patient to embark on a reconstruction. I put in here in bold and italics, the most important one. It seems pretty obvious, but good surgeons have been tricked into embarking on this without thinking about this first. The patient has to have full passive motion before you consider reconstruction, because you're not going to get any more motion with a hunter rod in there or with the opening up and reconstructing things. So they have to get it before you even start. The motion you start a 2-stage with is the motion you're going to end up with, if not worse. So they've got to get that full passive motion. And with this comes their ability to commit to rehabilitation. Where I practice, there are a lot of patients without great access to care and some psychosocial issues that lead to delayed presentation. So I have a lot of missed flexor tendon patients that show up hoping to have a quick fix, and more often than not, they end up not coming back for a reconstruction, because once I talk to them about needing the therapy and getting the motion ahead of time, they just can't commit to it. So this is important, and you need a motivated patient. So another interesting topic along with the lines of this is, would you reconstruct a digit with an intact FDS? So what if you did a FDS FDP repair, FDS is working great, but the FDP is just not coming along. So in general, we would say that it's a relative contraindication to reconstruct an FDP. That's sort of what's in the literature and maybe sort of the teaching, but a lot of people still would. I've done patients and done an FDP reconstruction. I think in general, most people would argue that you want to do this in younger patients where the chances of it being successful are better with the more supple tissues, and also the more years ahead of them that they need that strength for. And one, tip that I have is that if you're going to do a 2-stage reconstruction to regain FDP function with an intact FDS, it's probably worth taking down one of the FDS slips just to minimize the bulk in the zone 2 to increase your chances that this reconstruction is going to work. So then what about single-stage reconstruction versus a 2-stage reconstruction? This is very debatable. There's no great, answers as far as which one is best. But single stage meaning that you take them and you graft it reconstructed at the initial index revision surgery or primary surgery delayed basis. You can do this if the tendon sheath and pulleys are intact. If you can dilate and sufficiently pass tissue to get that graft through without having any too much of a tightness or bulkiness, then it's probably reasonable to try a single stage. And just for those of the younger ones in the audience, that this was the historical standard of care until the 1970s, and when Dr. Kleiner and Coots really revolutionized and started doing early repair. So this was for a long time what surgeons did. The 2-stage reconstruction is the one I, personally perform more in general. This you definitely have to do if there's a compromised tendon sheath or pulleys, but also surgeon preference. So just a few tips and pearls as we go through this, because I imagine there's a lot of practicing surgeons on the call, just some really, practical things to think about. So in the stage 1 reconstruction, what do you have to do? You've got to evaluate the tendons. You've got to figure out, are they cut? Are they just cut and scar tissue? Assuming but both tendons aren't working, you have to take out the non-functioning tendons. So clean out that pulley sheath, tendon sheath to get a nice gliding bed. So take out all of that scar tissue, all that remnant tendon. Don't forget to go dorsal to the tendon to really get that scar tissue out of there. Assess your sheaths and your pulleys like we've talked about already here. If it's reasonable, you can do a single stage reconstruction, but more than likely initiate the 2-stage. As far as pulley reconstructions, in general, we say that you need at least 3 pulleys preserved or reconstructed to undergo reconstruction. So historically, we've said A2 and A4 are the most crucial. If they aren't there, you must reconstruct them. But now, as we've heard from Dr. Tang, that's a little bit more of a debatable topic now. And so I think this is where the wide awake surgery can really come in handy too, to be able to assess for bowstring and things like that. So what do we use to reconstruct the pulley? You can really use a lot of different things. So my preferred is to use the excised tendon or some of the scar tissue. I do think that some of that scar tissue in there is strong enough, robust enough to perform a pulley reconstruction. You can also take palmaris, extensor retinaculum, or the FDS tendon. But you have to be thinking in this, especially for the junior surgeons just starting out and doing this on your own in practice. If you think, I'm going to take the palmaris, it's an easy graft, that's going to be great to reconstruct, you got to think about what you're going to do in the second stage. So don't take your good palmaris and then, hose yourself for the second stage. So just have some options. And the extensor retinaculum is an interesting one that I had come across in preparing for this talk that has some good outcomes and data because this is a synovial lined donor. So as far as the reconstruction, there's kind of two main ways to do it. You can do a looped reconstruction or a non-encircling reconstruction. Looped is stronger, we know that, but really it's kind of dealer's choice as far as what you're familiar with. Note that at the proximal phalanx, you can loop around 3 times because it's a bigger bone. And here you want to pass your graft between the bone and the extensor, so deep to the extensor. But once you get out to the middle phalanx in P2, you want to go superficial because that's where you've got your central slip insertion. And you can usually only get 2 loops around the middle phalanx. Here you're going to then use your silicone rod to make sure you have those in stock because not all ASCs and all surgery centers have these. It's kind of a one-off thing that us hand surgeons use. So be sure you've got these available. And what we know that the silicone rod does is it creates a mesothelial cell-lined pseudosheath for our tendon reconstruction to pass through. The rods can be active or passive. I use active. I think it's probably what's a little bit more common these days, but passive has been used with success in the past. And then you need to connect your tendon rod distally, either into the distal phalanx, or if you have some remnant tendon, you can suture into or adjacent tissue, anything that you need to make sure that you get a secure connection of the silicone distally. Pass it proximally into the palm or the forearm, depending on your preference. And then, kind of the question is, what do you do with that FDP and FDS stump? Do you tag them for later if you want to try to use them for the donor graft, or you just leave them be? I tend to just leave them alone and go to a different inset proximally in the future. I would be remiss if I didn't mention the Peneva-Holovic procedure, and this is where in the first stage reconstruction, you actually tag the FDS and FDP together and create a connection to those. So that way at your second stage, you harvest proximally and you've already got that end-to-end loop, so you only have one anastomosis to heal at the second stage. So this was created in the 1970s. It's been modified over the years, but is one to kind of keep in mind and use as an option potentially. After that first stage, you want to shut them down for a couple of days, let the incisions heal. Then you get them going right away with therapy, aggressive motion, aggressive edema control, get that scar mobilized and keep their tissues and joints moving so that you can do your reconstruction at 8 to 10 weeks or closer to 12. I prefer 12, but some authors have advocated for earlier second stage. At stage 2, this is one of the harder things to think about is you cannot peek. You open up limited incisions. I was interested to see Dr. Tang's primary reconstruction where he does the limited incisions. That's really ingenious, but it's super important for the second stage. You don't want to violate that sheath you just created. So you're just going to open up at your distal and proximal ends and get your silicone rod out and put your graft in place, harvest your graft, pass it, and insert it. So what are your options? There's a lot of options for this. I think it's important to understand and know and be familiar with multiple of these because every patient is different. A lot of people don't have a palmaris. Up to 20% of the 25% of the population does not have a palmaris longus. So you need to be able to understand what other options you have. Intersynovial, extrasynovial. There's not really any support in the literature to show that one is better than the other. So I think having a familiarity with lots of options behooves you as a hand surgeon. So you're going to pass your graft and secure it usually to the hunter rod and pull it through. You can also pass it with surgical wire, whatever you need to do. But one tip here is you should clamp, assuming you take proximal to distal, clamp that proximal end. So when you pull it through, you've always got the handle on it proximally because you don't want to lose your graft within your tunnel. And that makes for a sad day to have to go fish that out. You want to, more than likely, I would imagine all the other surgeons would agree with this, you want to secure distally first, because that's a little bit of a tougher spot to get into. And so if you fix it distally, then you can set your tension proximally. So distally, you can either use a suture anchor or, good old standby of a button with a pull-out suture through it, whichever technique works in your hands. But again, be familiar with both, because if you plan for an anchor, but then the tendon or the bone is not strong enough to hold it, you need to have your bail out of your button, make sure that you've got that available for yourself. And this is what that can look like here with pulling out your distal donor into the distal phalanx like we do for a zone 1 reconstruction. So then you're going to insert into your proximal donor. Usually we use the adjacent FDP as your donor, but there are other options too. And like we said, if you're using the Peneva-Holovic, you've already got that proximal donor secured. So then you're going to pull your tension, set your cascade and your flexion where you want it slightly over tensioned, and then weave it into your proximal. Generally, we recommend a pulver tuft weave over end-to-end repair just because it's a little bit stronger and you don't really need that gliding smoothness because you're out of the zone 2. And like I said, slightly over tension can be really helpful for this because you can have them check it. And if it's too loose or too tight, you can change it right away. And for that, I would pass my pulver tuft weave, kind of secure it with 1 or 2 simple sutures just to kind of hold it, have them check it. And then that way I can remove my suture and tighten it or loosen it as I need to. Important to know that we've talked about this. It's a fun surgery to do. It's exciting. But the outcomes, they're good, but they're not great. It's really important to talk with a patient that if you undergo a 2-stage reconstruction, it's probably not going to be the finger you had before all this happened. Dr. Amati looked at their experience at Mayo. This is a little bit of an older paper, but overall with 100 cases that underwent 2-stage reconstructions, only 54% had a good to excellent outcome. A relatively high rate of infections and complications. And the patients that did worse were those with zone 1 or 2 injuries, and the younger patients. Patients that did better were those in zone 4 or 5, as we would expect, and patients that underwent hand therapy. And then an even more original paper from the 1970s of Dr. Hunter, looking at their experience with the 2-stage reconstruction, overall showed that they thought the 2-stage did a little bit better than the single stage, and primary grafting for chronic injuries was less than the primary grafting. So back to our case. Like we said, open the patient up. Both tendons were out. For this patient, we used a palmaris longus graft for pulley reconstruction, a silicone passive rod sutured distally with suture rather than a suture anchor into the bone. At the second stage, limited openings to reconstruct it. Palmaris longus graft was harvested for that reconstruction. And you can see that here in setting distally. And slightly over tension there, showing the nice restoration of the cascade. I do have another case courtesy of one of my fellows who had an interesting case that this patient had a different graft option. I thought it was fun to show. So this was a female who actually had a missed injury rather than a ruptured repair. Came in at about 5 weeks to clinic and wished to have reconstruction. So at her first surgery, she did have a collapsed sheath. So they placed a silicone rod, is scheduled for the second stage surgery, which is what the photos are here for her coming back for her second stage. This particular patient did not want to violate her tattoo, and so she elected to go for a toe extensor for reconstruction. So you can see the harvesting of the 4th digit toe extensor. You can get that through a nice small limited incisions, kind of minimally invasive harvest. You get a lot of nice length on it, a good size match and donor match for the digital flexors. And here it is passing that graft from proximal to distal, insetting it, and then her final tension. So just some take-home messages, the flexor tendon misses happen. Repair failures are lower, 4% we see in the literature, but they can happen. So indications to reconstruct, we know, are supple and sensate digit and a committed patient to the rehab course. You can do a single or 2-stage reconstruction, depending on what we've talked about, the different factors and multiple graft options. Important to know all of them, or many of them, so that you have multiple options. Some of the pearls we talked about are really being, aggressive with your excision of scar, reconstruction of the pulleys with that first stage, and then make sure you're thinking about and planning for the second stage, what grafts you're going to use, what donors you're going to use, so you can plan your incisions and your harvesting appropriately. At that second surgery, you're going to use limited openings and connect distally, then set your tension proximally. It is a relatively challenging reconstruction, so just this is going to be the epitome of all of the hand surgery tips and pearls that you've learned, and important to set expectations with the patient at the start of their journey. That is all I have. I appreciate your time.
Yeah, thanks, Dr. Shaughnessy. Wonderful talk. I think really great pearls on how to tackle a real tough problem. Before we move on to our last speaker, I want to thank the audience for putting questions in the Q&A box. Please continue to do so. And I'd like to move to our final speaker, Greg Pitts, who's going to really give us, the therapy aspect of this and what's really critical in getting the outcomes we want and really how to make us surgeons look really good. So thanks, Greg. Go ahead.
I'm going to share my screen. Well, sorry about that. First of all, I'll say thank you. I'm very humbled and I appreciate the opportunity to share some thoughts with you today. We'll start on a personal note. I got passionate about hand therapy when I was very young. My dad was one of the first replants in the world in 1969 by Dr. Kleiner in Louisville, Kentucky. And he went on to become he was a blacksmith and a gunsmith. Lost him 10 years ago to cancer and Agent Orange, but he really affected my life and why I'm passionate about hands. Been a hand therapist for 35 years and I teach trauma for the U.S. Army. So the first thing up is we want to try to control the 7 major factors. I've kind of drawn into 7 major things that influence outcomes and in flexor tendons. And we really got to work on flexion and trying to diminish the work on flexion as we're doing rehab. We have to be able to evaluate the work on flexion because if we don't do a good job doing that, and we start off with the protocol and we don't control edema, we don't control the positioning, then we can have a rupture or a failure. So Dr. Reardon I got become close friends with him in 15 years ago, and he was always big on interpersonal communication with the patients. Wash their hands, take care of them, educate them on treatment approaches, teach them about expectations, and be direct with your communication. It's very, very important. You cannot be a passive therapist when you're working with these patients. The next one up is patient cognition. And I know we all talk about the bad patients, but they have to be able to follow 2 and 3-step commands, and they have to be able to demonstrate the home exercise program to you. We've all seen these people come in with their bandages dirty and the splints are dirty, and they're just not using good clinical judgment at home. And that's why we have to really watch these patients closely and bring them in as much as possible. So cognition, extremely important. The third one up, how many systems are involved with the injury? Was there bone involved? Was there loss of tendon length? Was there nerve injury? These things all play a huge role in how we splint them and how we treat them. And so we tend to think only about, okay, 6-strand repair of the tendon, but there's most of the time we see a multiple system that's injured. And we need to think about that as we're treating the patients. Edema control. Edema is extremely important to control, and I think that's probably the biggest point that therapists need to look at and think about a lot, and that is positioning. We know that if we start our programs early, the key point, most studies are showing that we catch you 3 days post-surgery and we can start putting you into a good orthotic, change your dressings, start you on a gentle passive range of motion program, and eventually into an active range of motion program, your results are going to be better. Whereas if we wait, we can be in big trouble. The lady at the top is Nancy Cannon. I think she's probably the best hand therapist in the world for flexor tendons that's living. And she's shown me several pearls. One is treating the edema using gauze and 2-inch and 1-inch wrap. Then put your Coban on top of it to control the swelling inside the protective orthotic at night when they sleep to help control the swelling. And also put the hand in a non-dependent position over their chest or a pillow over their chest when they sleep at night. Makes a huge difference. The other is kinesio tape and edema gloves. Just beware of the edema gloves and make sure you break the elastic at the proximal end so it doesn't become a tourniquet. Early active motion programs, that's kind of what everybody's here for tonight. We know that if we start motion early, that we'll have a better scar formation, we'll have decrease in adhesions, and I think everybody knows that this is done, that there was a lot of studies done and demonstrated that if you start early, you have a less work on flexion than if you wait or delay the motion, you're going to have much more drag from scar tissue that will end up with a bad result. So 6-strand repairs in a totally point blank tendon only. We're now at orthotics where you've got the MCPs at somewhere between 60 and 70 degrees of flexion. The wrist is in 20 or 30 degrees of extension to take away the extension mechanisms, work on flexion. This is for a 6-strand repair. 4-strand repairs are still wrist in neutral or 20 degrees of flexion. Also, if you lose bone substance or tendon substance, that will change it. So we're always thinking about what is the work on flexion, what was fixed, what can we do to help make the outcome better. And then we look at modified Duran, and Dr. Dr. Tang talked about, passive range of motion. So it's very important to focus on the DIP joint and flexion independently, and then the PIP joint, and then your composite fist with each individual finger throughout the treatment session. And you do this with the patient, they demonstrate it to you, and then we tell them to do 4 to 6 sessions per day. We add 10 reps per week as we progress these patients through their program. We also do wrist flexion with digital flexion to diminish the extrinsic tightness and intrinsic tightness that occurs from these injuries. Extremely important. And then we start our active range of motion program. Week 1, I put 4 digits up, and this is my only my technique. And I change a digit. I show the patient I do it. Put your hand in your palm and move to your fingers, and they're in the splint and they're moving nicely. And then the second week we go down to the third finger, and they're moving nicely, and they have a point of aim or point of control that they're looking at, so they understand what they're doing. And we've been very happy with this approach. Another thing to think about is that we are, with active range of motion programs early in the process, we are maintaining brain plasticity, because we all know that if we cut a finger off, we lose it off the brain in 2 weeks. Well, the innovation of early active motion is changing that and making the rehab very, very easy on the second phase of rehab. They're in the motor control and strengthening phase, because the tendon stays connected to the brain. It's very important to think about that benefit from early motion. Here's a short video that shows early motion. So 4-finger repair in zone 2, and he's at 2 weeks out. He's at 2 fingers, moving incredibly good. And then I also do place and holds, and I know that's controversial, but if the swelling is down and there's a lack of work on flexion, and the flexor tendon is at 3 to 4 weeks, we start place and holds, because I want to try to get that terminal flexion that occurs in the hand. And it's very, very important to
Place and hold.
look at that. And I'll show this real
10
quick.
seconds. And then you will flex the wrist and extend the digits with the hand blocking. Good. And hold that for 10, and then you'll go back into the place and hold pattern, where he places it with his non-effective.
All right, the other video shows active motion with sponges, and this patient's about 4 to 5 weeks out, and we actually put sponges so the fingers can't trap each other. The fingers will accommodate and trap the other finger, the injured finger, and make it look like you have a good fist going on, a good tendon gliding, when actually you don't. So just something to think about as you're doing your rehab process. I'm showing this because this is something we've been working on for a little while now, about 5 years. We have a cohort of about 40 plus patients, but it's a dynamic crane. This is for zone 3, 4s, and 5s, but it demonstrates the need for early motion. And we start this at day 8 to 10, and they go through an active range of motion with the crane. The tension stays constant through the full active range of motion. You can facilitate range of motion, edema control, avoid tendon sticking and adhesions, and we get great results with this. The tension changes as you change the crane position from 1, 2, and 3. I was taught this back in 1990 by Stephen Chesser. This is the same concept that we use for the replant hand. And we've been using this with replant hand for 25 years, and I don't know why we can't use it for flexor tendons, particularly 3, 4, and 5 zone. We showed this. Next, joint stiffness. How do you treat joint stiffness? Well, at 4 weeks, we actually put a device, punch a hole through the dorsal block, and we actually start applying stress to end range and slowly walk the volar plate out. At 6 weeks, we go with a hand-based orthotic and do basically the same concept to pull and fix the volar plate. So these are nice concepts to be used to fix volar plate problems and stiffness. We do joint mobilization. We start joint mobilization actually at week 1 with grade 1, 2 joint mobs, and at week 4 we're doing grade 3 joint mobs at end range. We also do serial casting at 6 weeks and also tube orthotics at 6 to 8 weeks. Muscle activation. We use muscle stem as early as 3 weeks at a very low level to facilitate tendon glide, and also to work on edema and swelling. And one point I want to make, and that is that when you're doing passive range of motion and the finger is swollen, you've got to go really slow and controlled and let the edema escape and move. If you push fast, all it's going to do is it's going to bounce off the swelling. It's going to have a higher pain reflex, and the patient's going to be scared and frustrated. So when you're going in passive range of motion, go slow when you have high edema. Last but not least, corrective orthotics we use. We use an intrinsic orthotic, stretch orthotic, lengthening at 6 weeks, and we use a static progressive orthotic to lengthen out the extrinsic flexors at 6 to 8 weeks. And that's all. Thank you.
Wonderful. Thanks, Greg. Well, I think we are right on time here. So I want to really thank our faculty for really wonderful talks. I learned so much from each one of your talks, so thank you so much. And thank you, the audience, for being with us. Hopefully you learned a little bit about Zone 2 flexor tendons today, and stay tuned for our upcoming webinars. Thank you and good night.
Thank you.
Thank you.
Okay, thank you.
Recording stopped.